Today we'll talk about service PPPs in the Asia Pacific trends and challenges. But I'll be covering slightly broader issues because I think it's important to understand the role of the private sector. Because it's only when you understand the role of the private sector, you know what service you want to get. And then mechanisms to integrate tools and to redefine the role of the private sector for UHC, because it's the whole course about UHC. And then how public-private partnerships can expand access for UHC. So it's related. So when we do service PPPs, obviously it's for an objective. The objective is really to improve access. Just a reminder about what the private sector is. The private sector is not just about provision, it's financing sources. So it's anything outside the public sector, whether they are not-for-profit or philanthropic, or commercial or for business. And the primary aim is to treat illness or prevent disease. So when you look at this, I don't know whether you've looked at this before, you can have public delivery, public financing, which you're used to, such as in the National Health Service. But you can also have public financing with private delivery. So I'm sure that people have taught you on the financing systems. In many social health insurance systems, the funding is public, because social health insurance is considered public because it's mandated to be paid, and then all from taxation. But you can also have private delivery. So in Thailand, in Korea, in Japan, the social health insurance is public, but much of the delivery of both hospital and primary care is in the private sector. So many of the European countries, their sickness funds are public financing, but the delivery is done by the private sector. And of course, the government can also contract out services. So like in many of the tax-based systems, increasingly, that's why we have this course, that governments now, instead of providing service themselves, they're starting to contract out space services to the private sector. So this is the part that we're going to talk about today. But you can also have public delivery of private financing. So any fees, any co-payments paid to public providers is considered private financing. So anything that doesn't go either through taxation or social health insurance is private financing. And of course, there are informal payments in some systems that you pay to public providers. And of course, private financing, private delivery, you are familiar with that. And of course, in Asia, you can see that we have a different public-private mix in our Asian communities. In many countries, in Indonesia, Hong Kong, Sri Lanka, Malaysia, Japan, about half and half of the financing is public, right? And of course, on the right side, in countries where either they're small countries or there's social health insurance, predominant of the funding is public. So this is just the government expenditure and the provisional hospital beds. You can see that many countries that the expenditure is public, half is public, but a lot of the hospital beds are private, and of course the government expenditure, total health expenditure, you can see that many countries are somewhere in the middle, about 50% are public and private. It's only in countries where there is social health insurance that you have more public provision financing. So these are just primary care services in OECD experiences. So you can see that it's quite variable. So primary care service proportion are provided in the private sector in different proportions. So there's quite a large variation, right? So in private hospitals play in different financial systems, in social health insurance systems, the private sector, as I said, functions as part of the health system. So they engage through the social health insurance. Public hospitals may be corporatized and compete with private hospitals, but historically, many of these countries, the private hospital predominate. In tax-based systems, it's usually the role of the private sector is very much influenced by the markets and driven by the government policies, depending on how government policies are, and we'll discuss that a bit later. Importantly, the private sector is a source of care in anywhere in the world, right? So you can see that these are just experiences from different countries. That's why we need to look at the role of the private sector. So even in the poorest countries and the lowest economic groups, people consult private providers because of ease of access, availability of staff and drugs, sometimes increased confidentiality and high technical competency, and perception that private providers are more caring and responsive. And of course, there are user charges in the public system, and the accessibility of public services is a problem in many systems, and particularly in our tax-based systems in Asia, where our public services are limited. So the role of the private sector, you can see that the private sector is, in terms of financing, is a whole range of things: co-payments, user fees, private health insurance. It can also be financing for infrastructure. We talk about the infrastructure PPP. As providers, they can provide services, but it can also be investors in many countries. So don't only think about private sector as just providing services. They provide a whole range of different types of roles in the private sector. They can be consultants. They can own premises. They can organize and manage. They can invest or just provide services. Of course, they're also part of that governance and leadership, because they also provide governance in terms of the policies in private hospitals, the governance structures, determine in terms of the care that you get. The insurance industry will have many conditions in terms of how you are reimbursed. So the workforce, much of this is private, and much of the production of medical products and technologies is private. So you can see that the private sector is not just about providing services, right? So they have a whole range of roles. So in Asia, they're involved in financing and capital investments and insurance. So you know that there are organizations like BUPA, the IH group in Malaysia is the biggest hospital provider in the world. It's a private company which is listed in the stock market. They can also be entrepreneurs. They can also be involved in regulations. Right? So we know that the private sector is integral to all health systems. It influences access, equity, quality, cost effectiveness. It's a key resource for if you want to improve universal health coverage. And there's a potential capacity which we should use. So how do we then capture these roles so that they become an essential partner for intricate care for chronic disease burden? Of course, we have talked about integrated care and the importance of that, because increasingly in all countries where you have aging populations, and even in countries where the populations are younger, chronic disease is a big problem. Of course, chronic disease, one needs to have a more integrated care, from preventive to curative to palliative, right? And this is required, because unless you have this continuity of care, the care quality tends to be poor. It tends to be segmented, fragmented, and inefficient and ineffective. Right? So all countries are now looking towards how to really improve access, and then how to improve the quality of care through integration, especially for chronic disease. Right? So who defines the role and how it's defined? Of course, the role is defined by, in some countries, because you have called international organizations that give money to governments. They are philanthropic organizations. These transnational enterprises and global health foundations, and then governments themselves, in terms of whether they have explicit or implicit policies or by default. The markets determine it. Obviously, the market looks at what's needed and they provide it. And then obviously the market's very good at providing new services and new products. There's civil society in terms of advocacy, participation, and engagement. So these are, so it's not just a simple matter of just who the government deciding or the private sector. So it's really the mechanisms within that particular context in that country. So when you look at the private sector in Asia, the demand is supply and demand question. So in terms of the demand, obviously patients look for better quality, access, convenience, responsiveness. International patients, because you have a lot of medical tourism in this part of the world, they also look at quality, cost, and convenience. Of course, on the supply side, government policies are important. in terms of their policies that stimulate or enhance or enable markets, whether they provide adequate investments, the oversight and quality and access, and whether there's investment in health services. Of course, the private sector responds to markets, responds to new markets, and responds to government policies. So these is the dynamics of the demand and supply equation, and the roles played by the patients, both nationally and internationally, and the role played by government and the private sectors. Right? So what are the mechanisms to redefine the role of the private sector for UHC? So these are the so-called government policies, which we talked about already, or government tools. So exhortation is persuasion. So you can give consumer information. It's very powerful. So we'll mention some of that later. Just giving people information can influence the patients. Obviously, in much of the health education, it's really persuading people to improve their lifestyles and improve their health, right? So that's exhortation or persuasion. Taxation is very powerful because, like, if you give tax incentives for disincentives for certain things. So for private health insurance, governments give incentives for people to buy it. For tobacco and sin tax, those are the disincentives for you to smoke to improve health. Government can also provide tax holidays for private sector if they want them to develop the hospital industry in that country. Expenditure is simple. I mean, you already know about that. So it can either be subsidies, contracting, and we'll be covering mainly this part in this lecture through financing, through either contracting on the supply side or vouchers on the demand side. Right? So I'll be talking a bit about the expenditure part, because you then are the tools that government uses to integrate care and to engage the private sector. Regulations we already talked about in the last session. I won't repeat that. Of course, government itself can provide it. Of course, that this one will exclude the private sector, but it influences the private sector. So even if government doesn't purchase care from the private sector, but it provides high quality care, accessible care, then it tends to squeeze out the private sector. Then private sector also has to respond. So this policy is quite clear in Singapore. The Singapore government explicitly states that they want to have about a quarter of the private hospital market so that people can benchmark. So it's used then to influence the private sector, make sure that people have an option. So people who have the resources can buy private healthcare in the public sector, or they can also buy private healthcare in the private sector. So it benchmarks in terms of what you can expect with the same dollar, the quality and the type of care in the public sector. So it then provides a benchmark to influence the private sector. So this is this is not a direct regulation or a direct expenditure, but it's a form of persuasion. So government is providing information so that people can choose. Right? So I know you have already covered this public-private partnership. So it's a means of getting actors together for a common goal to improve the health of populations, right? So this is the concept that what we're trying to do is that we're really trying to improve the health of populations, and the private sector is engaged for a specific purpose to improve access, to improve health, right? So this is a OECD definition. It's the agreement between the government or more private providers, according to the public partners deliver service, such that the objectives of the government align with the profit objectives of the private partners. So there is very clearly stating is how to design a partnership where the objectives, social objectives, are aligned with the profit objectives. So we recognize that the private sector is is there, and its purpose is to make a profit and to harness that for public goals. And the effectiveness of the alignment is a sufficient transfer of risk to the private partners. So it's really the proportion in terms of if I contract with you, you also need to bear the risk, right? So that's the concept. One of the things, of course, in the literature, and I throw this out because it's based on the study that we did, that there is the concept of PPP lacks specificity and consistency. It is used in different operations. So we won't enter into the equation except that it's used really to use the resources of the private sector to align it with the objectives of the public sector, right? So, and then to accept and to permit the private sector to make the profit. So obviously one needs to see how one designs a contract and which are the ones that the private sector can play a role in. So it will depend on the context of the country, depends on the responses from the private sector, and then on the contracts themselves. So I know you already had the session on the PPP for infrastructure. Today we are looking really in terms of the PPPs for services, not service delivery. So we concentrate on that. So I said there are two models. One is for infrastructure, building hospitals, clinics, services on the facilities. The other is for actual health-related services. So I won't cover this. This has already been covered by Professor Chantel and Serapan. The types of PPP, just to remind you. And the challenges of gauging is there are many. Usually there are need to have political commitment. So this will apply for both, right? So this is done by conducted survey by Rockefeller Foundation. There needs to be economic incentives sufficient to interest them. Then also you need to have the social interests of the private sector. There are poor mechanisms for regulatory quality provided by the private sector. And of course, government policy is required and a clear legal framework. So these barriers are really conditions for an effective PPP. And most of these were in fact the study was related to more infrastructure PPPs. This study which we did in Hong Kong by Professor Eliza Wong really was more in terms of the PPPs for service contracts. So the key factors for partnership, there must be trust, there must be defined roles and objectives, there must be time commitment, information must be transparent and candid, there must be flexibility in the contract. And then of course there's a lot of technical assistance required because the procedural arrangement, the operation can be complex. And then acceptance and awareness of the structural change related to responsibility and delegation of power. So I just want to cover the PPPs in Hong Kong, the spectrum that we had, and then later on to really look in terms of how one should be the deciding on the purchase of the types of services. So in Hong Kong, we started off in 1991 by setting up the Hospital Authority, where we corporatized, so it's not a private organization, it's still public. And then because of the series of reforms that government provided and really didn't, with very little effects on the financing system, because the different financing systems we looked at, and there was no agreement in terms of how we proceed. So we finally ended up with very little financing reforms except to restructure the fee charges. So and then because of the corporatization of the public sector, the quality of services was improving. So the public sector was attracting more and more private patients. Of course, then you have the pressure, the demand, and the government had to pour more money in. So then there were a lot of issues in terms of the available accessibility and the pressures on the public system. So government in the year 2000 started to look at how to improve the public-private interface, what we initially called that then. And then government started looking at how to reposition the public and private sectors. So the actual the PPPs, so-called PPPs, started the guide to PPP in 2008. And then they had a series of different types of PPP, which we'll talk about later. So these were the actual PPPs. Originally, they started with information. So persuasion, remember, information is quite powerful. So there's an auto reply project. So because the public system in Hong Kong is almost fully automated, so patient records are in the outpatients are all computerized. So there is a paperless record in the outpatients. Inpatients, there's a very integrated clinical management system where patient records are captured and discharge summaries are captured. And then all the laboratory and radiology are automated and they captured into one patient record. So there's a very good integrated electronic patient record for all the patients in the public sector, and of course the hospital sector in Hong Kong. 90% of all hospitalizations are in the public sector, so this is a good record. So in order to encourage the integration, we started off with the so-called auto reply project. So we started it because all the patients are supposed to have case summaries. So then at that time, in fact, I was the secretary. I said, why can't we just have an auto reply system in terms of just automatically, because you can just press on the button and you can capture the summary of the patients and send it back to the referring doctor. So that was the first start. So then we started looking at how to share patient records with the private sector, obviously with the patient's consent. And then actual PPP started in 2008 with purchasing cataract surgery from the private sector, purchasing outpatient care. We also had an influenza vaccine subsidy, because prior to that, whenever there's a program for vaccination, it will be the health department that'll be providing the vaccine itself. So in 2008, we started involving the private sector to provide influenza vaccines during the influenza season, and giving subsidies to patients. So you can go to a private GP and get your shots for influenza, and then the government subsidizes like $100 for each shot. So then this was part of that PPP. So it then went on to the influenza vaccine program, and then the human swine influenza vaccine, and then the elderly health voucher, and then shared care programs, patient empowerment dialysis. So I'll talk about these, because some of these are very effective. These were effective when they are one-off things. And then later on, we then went on to do the general outpatient. So it's primary care PPPs, and then colonic cancer screening PPPs, and glaucoma PPPs. So these are just the descriptions of the PPPs in terms of the how it's initiated, the service instrument. So you can see that the instrument was all service contracting. So you can see that for the first 6, they are service contracting, and the last one is really persuading people to go for X-rays. And then you have the financial arrangements, the function transfers, the ownership of the private sector, activities of the private sector, and the public. So I won't go into the details, but just to go into some of these programs. But this is just for your reference. There's a paper that we published in 2015 looking at all the PPPs in Hong Kong. So it's quite good reference for you to look at. Right? I just want to cover a few, some which are successful, some which are not, right? And then through that, you can also understand some of the complexities, and for some which are quite easy to do. So usually one-off programs can be successful, and if you plan them well. So this was a cataract surgery program because of the aging population. The waiting list for cataract surgery was quite long. So that was the objective, because there was also in the, and then I think you've been given the programs on private health care, private health sector assessment. There were really a lot of private ophthalmologists, very well qualified, and doing cataract. So this is an ideal program where you have a large private market. And the private market was quite ready to do this because these are large volume patients. It's a simple procedure, and the arrangements can be quite well organized and managed, and the risk is low. So the government then decided to give a subsidy for a patient of $5,000 to have cataract surgery for one eye from any private ophthalmologist. So there was no credentialing system, except that if they're all qualified as specialist ophthalmologists, because Hong Kong has an Academy of Medicine. So all specialists have got to pass a qualifying exam. And if after they pass it, then they can practice as specialists in ophthalmology. So there were any ophthalmology ophthalmologist who is recognized by the Hong Kong Academy of Medicine was eligible to do the surgery on the subsidized scheme. But the government also was quite good, because they said that this was the first PPP. So of course, patients in the private sector were paying approximately $10,000 to $10,000 and above. So the government said that they could charge patients a co-payment. So it's up to the patient. But for this scheme, if you want to take part in the scheme, you cannot charge more than $8,000 co-payment. So it gave the private sector an incentive to accept these public patients. Because if you just give $5,000, the private sector will because they can earn much more from their private patients. They would not. Many of them wouldn't take this up. So it was quite a good program in terms of the market survey that was done before to know approximately what the private sector was charging. Also, but what they didn't do was they didn't look at the willingness to pay on the private sector. But anyway, government will pilot it. And the package, it was a package. It involved not just the surgery, but one preoperative assessment, the surgery itself and the lens, and then 2 post-operative checks. Because it's quite, as one knows, that for cataract surgery, the norm would be 1 pre-op and maybe 1 post-op check. So it involved that package, so patients knew what's involved. Because unless patients know what their layouts are going to be, they're not likely to take this up. So these were all patients in the public sector. In the public sector, if you have cataract surgery done, they don't have to pay these fees. They only pay the public sector fee, which is usually, if it's an outpatient, they'll only pay 75 Hong Kong dollars. So it's substantially more. But of course, the incentive is that this was subsidized, and they could choose the private doctor they wanted to have the surgery from, and then it was more timely, so they didn't have to wait, right? So this was how the program was designed. It was very successful, and it's something that government is now continuing with. So not all the patients in the public sector opt to take this, but for those who want to have cataract surgery done earlier, many of them take up this offer. So this reduces waiting time. Then there was this general outpatient public-private partnership. So the concept, because of our public system, about 25%, only about 25% of primary care is provided in the public sector. So there's a limit to the number of patients that we can see. And the difficulty is, of course, the public sector, the user fees are quite modest, $50 for each time you see a doctor. In the private sector, if you go and see a private GP, it would cost you approximately $300 for the consultation. And then with some drugs. But of course, in patients with chronic disease, the drugs are maybe more expensive. So it would exceed that. And then if you have a chronic disease, you also need to have investigations and x-rays and things like that. And of course, the $300 in practice doesn't cover that. So the problem is that in our system, when patients have diabetes and hypertension, chronic disease, they are referred to the public sector, and patients then do not wish to go back to the private sector because they have to pay out of pocket when they go to the private sector. In the public sector, all their investigations and drugs are covered with just a flat $50 fee for the consultation and $10 for drugs, right, for each drug that is prescribed. And not even if it's prescribed for 6 months, a prescription will only cost $10 Hong Kong. So you can imagine the price differential. So the government then designed this program to identify patients with stable hypertension or high blood pressure and diabetes, to invite them to participate, and then to have a choice of voluntary private doctors. So they were given a choice. And for each participation, the government subsidized 10 visits. So because they had looked at the data, because in the public sector, they would probably only be seen about 4 or 5 times. Of course, then it was quite generous. So they estimate that perhaps they could have some intercurrent illnesses, or sometimes they may need to more frequent consultations. So it's quite a good design program, but it's quite expensive because the government subsidized people to go to the private sector, and the patients only have to pay the same co-payments as they would pay for in the public sector. So it meant that they would pay only $50. So the government is subsidizing $3,400 to cover a maximum of 10 consultations. So the participating doctors receive this lump sum of $3,000 a year to cover 10 consultations. So obviously, if the patient doesn't go for the 10 consultation, the doctor still gets that sum of money, right? So this is how the program is organized. So it's quite an expensive program. So the objective is really then to engage the private sector. So they are providing, they're contracted to provide chronic disease management from the public sector, and getting quite optimal payments of 3,400. So of course, through this program, government needs also to look at the quality. So there are patient records. They're required to follow certain protocols. But I think this program, although it's been quite successful in downloading 20 to 30,000 patients from the public sector, is still quite limited. And of course, there's the evaluation of the quality of care has not really been verified externally. But it's an interesting program because it's structured in terms of looking at the types of care required, looking at the fee charges, and then the arrangements for the private doctor to provide this care. This is also an interesting program because government decided to provide colon cancer screening for the general population, and the patients obviously have a fecal or cord blood. And then later, if it's positive, they have got to wait for colonoscopy, and there's a waiting list for colonoscopy. So the public sector offers 6,800 for one colonoscopy if there's no polypectomy, and then 7,500 with a polypectomy, and then to have a minimum copayment of $1,000, but additional fees can be charged by the private sector. So you see the programs are quite different. Some you cap the copayments, some you permit limited copayments. So obviously one needs to look at the market and what doctors are likely to charge. So I think one of the reasons they did this, that they thought that because when they were engaging with the private specialists, the number of colonoscopists is not as many as ophthalmologists, right? So they wanted to incentivize the private sector to do it, and then permitted them to charge co-payments, right? So this was really entirely a choice for patients, because if they wanted to shorten the waiting list and the willingness to pay was higher, and then they could also choose different providers who might charge differently. And then this is for infirmary. So there's also contracting with private sector to provide infirm services. So it's more contract service for long-term care. And then glaucoma. Glaucoma is also something that is quite problematic. So of course it's chronic care. So they also looked at for patients with stable glaucoma, because they go on to the public sector ophthalmology service, and of course there's a long queue. So they just want to then, these stabilized patients are then referred to the private sector, and then the patients usually pay the same as they would from the public sector, so that they would have incentive for people to go. And then the ophthalmologists are given the maximum service fee, covering consultations, some tests. So you can see for the service PPPs, for the chronic disease, usually the government will look at a package of services and then pay the public sector, the private sector, a maximum service fee or a set service fee to cover the consultation, the investigations, and patients only pay for the co-payments as if they were in the public sector. So this will encourage people to go to the private sector. But for one-off programs like cataract, colonoscopy, which is one-off, patients are more willing to pay more. So then the subsidies are less, and patients' co-payments are higher. So you can see the difference between the two types of service PPPs and the payment mechanisms, right? I want to cover this. When we talk about service PPPs, there are two instruments that one can use. You can have the so-called supply side, which is for contracting. So you use so the contracting can be or the expenditure. Remember, one of the tools of government to engage private is expenditure using money, but the money can be given to the provider. So this on the supply side. So just now, when we talk about all those programs, they were on supply side, but the demand side is using vouchers. So you give the money to the patient, and then the patient uses it to purchase services, right? So for the vaccination subsidies, that's voucher. The entitlements is a voucher, which is given to elderly people to get influenza shots from the private sector, children to get influenza vaccination from the private sector. Those are demand side tools, but the other ones were supply, right? So one needs to understand in terms of when one should be using supply or demand side method tools to purchase service from the private sector. So this is both purchasing, but using either demand side, which is direct contracting with the provider, or using vouchers, which is really giving the options to the patient, right? So this is a elderly health voucher. So it started in 2009, and people were given, all the older people aged over 70 were given vouchers $50 each. But this, when it started, there was only 5 vouchers to choose healthcare services. So they could buy from any doctor in Hong Kong. And the incentive was really for them to give this money, for them to encourage them to see private doctors to help to establish a closer relationship with the private doctors and help promote this concept of a family doctor, right? So I'll cover this in greater detail because we did an evaluation of this and there were a lot of issues, right? And then we'll be discussing them when one would use a voucher or a contracting. So I just want to cover, I know that strategic purchasing can be briefly covered, but I just want to repeat that again. Of course, UHC is ensuring all people have access to the needed promotive, preventive, curative, rehabilitative service of sufficient quality to be effective. So it's really providing integrated care, right? So you look at all these elements, all the elements of care, and also ensuring they do not suffer financial hardship when paying for these services. Right? So you remember that this diagram. So it's really in terms of universal health coverage, who is covered? Do we cover everyone entitled? What services are covered? And then how much is the cost sharing? So these are the 3 elements of UHC. And then the objective is to try to expand services and interventions, improve quality, advance equity, financial protection, optimize efficiency, and improve outcomes. Right? So for us to get there, we talk about strategic purchasing. Very often government purchases or commissions. When we talk purchasing, we purchase from the private sector. When we provide services, it's usually called commissioning. But in fact, it's the same concept. In fact, when we're trying to buy care for the population, we should be more using a strategic approach. So, but many governments use a more passive approach. So you follow a predetermined budget or simply paying bills when presented for services to be or have been provided, right? Strategic purchasing is to continue search for the best way to maximize health system performance by deciding which intervention. So you need to decide which are the ones we want to purchase, how and from whom. So identify the interventions or services to purchase based on population needs, national health priorities, and cost effectiveness. To commission, which I said that if you internally, you can either make or you buy. So I'll discuss that later. So when you want to contract PPPs, you should be also looking, why shouldn't I do it myself? What's the objective of purchasing? Can I not do it better myself? Or is there a market? Or do we want to use the market better to provide competition? So one needs to consider the question before you buy, whether you should make, right? And then to choose service suppliers based on the capacity, availability, quality, efficiency, and equity. And importantly, once you decide that, to determine how to purchase. So whether you want to use demand side, which I talked about the vouchers, or supply side instruments, and if you use supply side, the contractual mechanisms and the provider payment mechanisms. But very often on the demand side, one also needs to look at some of the provider mechanisms as well, right? So it's not just usually just either or, but the main tool, because in many supply side, one doesn't look at the demand side. On the demand side, one also needs to also address some of the issues in the supply side. So you need to set aside the needs, preferences, and values of the population, fill the service delivery gaps, inform the population of entitlements and obligations, ensure the population can access the entitlements. So when you do a voucher, people must know what the entitlements are. So I'll discuss it later in terms of voucher, and then because unless people know what is there to buy and how they should buy, it's very difficult. How do they actually choose the providers, for instance? Right? So you need to have information. Mechanisms to receive and respond to complaints and feedback, and then public reports on how resources are used and measure performance and accountability of the purchaser. Right? So you select providers, establish contracts, develop formulas, design and modify provider mechanisms, establish the payment rates, secure information, monitor performance, audit providers, protect against fraud and corruption, establish and monitor user payments. So these are some of the actions that we use if you start doing service contracts, how you would design and then monitor and know what you're getting for money in Hong Kong. So I'll discuss this in the context of Hong Kong, the segmentation in our system. So we have a public system and a private delivery. And the way that one influences the private sector is through policy instruments. In terms of funding, you can see these are over the 4 years. Government funding is about 50% of total health expenditure. And most of the private funding is private household out of pocket. Private insurance only plays a relatively small role. And this is quite common in many Asian jurisdictions. Private insurance plays only about 10% or even less of the total healthcare expenditure. But you see that we have a segmented system that we have in terms of financing. The government provides 49%, but in terms of provision, 74% of the services are provided by the public sector, and in terms of outpatient, 30%. So we have a two-segmented system where the government funds predominantly hospital services, and then the private funds predominantly and provides private outpatient services. Of course, with the increasing years, we have more and more chronic disease. So I've showed this before. That on the green side is 2014, and the top lighter bars are people with no chronic disease. But when you start with about 45, about half the population will have one chronic disease, and by the time you're 80, you will have likely have about 5% of 6 chronic diseases. Right? So this is the problem in Hong Kong, that when people don't have chronic disease on the top, that the proportion of people use outpatients or primary care, 56% use private, 24% public, 11% both. But when in the brown, when you have one chronic disease, people migrate to the public system. So 81% of people with chronic disease use the public sector, and 44.7% use both, because people can't afford chronic care in the private sector, so they all come to the public sector. And the public sector supply is inadequate, so they then duplicate care in the private sector when they can't get an appointment in the public sector. Right? So you can see that that problem relates to then we have a very large avoidable readmissions, so people are readmitted within 30 days, 20% of hospital admissions. And then we have about half of the admissions are due to what we call ambulatory care sensitive conditions. And what they, where good outpatient care can prevent the need of hospitalization, timely effect outpatient and reduce the risk of hospitalization, early intervention can prevent complications of more severe disease. So this highlights in chronic disease, you need to have good ambulatory care. And of course, in Hong Kong then, where most of the outpatient or ambulatory care is provided by the private sector, you have a problem. So that's why government then started looking at the purchasing for primary care for chronic disease in the private sector. Right? So purchasing from the private sector. So these were the programs that I talked about. We have the outpatient program. The amount of money that government spends in terms of purchasing primary care. So the government, in terms of providing 25% of care, the outlay every year is about 3.5 billion. And then through the general outpatient purchasing schemes is 3 billion. So you can see that government spends quite a bit of money on primary care. But in terms of direct provision, it's almost 4 billion. But what I want you to look at is the PPP programs, the elderly health voucher. The elderly health voucher is funded for 2018-19, and we don't have the last year's figures. You can see it's 3 billion. So you can see that the 3 billion for the PPP program for the elderly health voucher is equivalent to the total funding on the top of the general outpatients. So this is for about 3.4 billion is for all our primary care services that we provide in the public sector. So very substantial. So you can see that government is already almost, including the general outpatient PPP, the amount of money that government is using to purchase primary care for the population is already equivalent to its own provision, right? So what effect has that had? Right? So when you look at the voucher scheme, the government then, it started 2009, is now no longer pilot, it's a recurrent, which means that it's an established program, and it's funded by recurrently from taxes. So at the moment, each elderly person aged over 65 can have $2,000. And the voucher amount is also $1 per voucher. It's $1 per voucher because if you have $50, the doctors are obliged to charge every $50. If it's considered $1, which means that they have flexibility to charge like $301 or $302. But if the voucher amount is 50, because you can't deduct less than the voucher and each voucher, right? So that's why you talk about $1 per voucher. So they can charge up to differentials of $1. So you can see that for every year, anyone aged over 65, irrespective of their financial status, has a voucher of $2,000, and it can accumulate up to $5,000 if they don't use it. And there are 10 eligible health providers, right? This is universal. So it's used through an electronic platform. It's quite simple because everyone in Hong Kong has a Hong Kong identity card. So what they just do is they just produce their identity cards, and it's automatically entitled to it. So what they do is they choose they look at providers who are enrolled in the scheme, because not everyone is enrolled. About 30% of docs are enrolled, and then the health professional then will go into the electronic health system for the individual account. Obviously, the patient will have to show the ID and then give permission then to open his or her account, right? Because it's only with the ID that they can open their account. So then they check the account to say that there's sufficient balance, and then for the doctor or health professional to deduct the deduction, they need to sign a consent form by the elderly to document that service were actually provided, right? So it's a simple mechanism using the electronic system, right? So patients there are no actual paper vouchers, but the paper records still need to be there, because in order to document that the patient had actually been seen and the patient had consented to the charges, the patient needs consent, because the $2,000 is open-ended and doctors can charge anything, right? So they can charge $2,000 for one visit, or they can charge $200 for one visit. It's entirely between the patient and the doctor, right? I'll skip this. You can see that because of the progression of the scheme, by 2018 we're already spending 2.8 billion. So a lot of money. So how do we evaluate that? So we did the research on this and to evaluate the use of the vouchers. And when you look at the voucher claims, they're used. What I don't highlight here is in the orange bars are the claims for acute episode conditions. So most of the claims were 78%, 80% were for acute episode services. The the top one are the orange bars are for preventive services, and then the orange bar, the darker orange bars are for chronic disease. So most of them were for acute chronic disease. Right? And when you look at the practicing private practitioners that participate in the scheme, it's quite varied. For very few nurses participated, very few occupations that participated. Most of the people that participated were the optometrists. Right? And when you look at the claims, you can see the per claim, the optometrists the claims were the highest, almost $2,000. And the reason for that is because many of the older people go to the optometrist, they have their eyes checked, and then the optometrist prescribes lenses, and they use that money to purchase their designer frames. Right? So that, because there's no control, so it's up to the practitioner what they want to charge, and for the individual in terms of what service they want to purchase. So when you look at that, it doesn't seem to be a very well-designed scheme because it's not specified the types of things that you provide. And patients are very confused in terms of having all these lists of primary care practitioners. And the problem is, of course, that people don't understand primary care nursing as well. Right? And when you look at because the objective was really to try to decrease the load of the public sector. When they looked at the choice between public and private, you can see that prior to voucher use, 49% of people use both public and private. But after vouchers, 60% use both public and private. And when you look at the green bars, it's in terms of private sector alone. Before the voucher, 22% only saw private doctors. But after that, 19% you see both public and private. And more importantly, you look at the orange or orange-brown bars in the middle. Before voucher, 24% saw public doctors only. But after the voucher, only 70% use public doctors. So what the voucher has done is has not decreased the public sector workload. In fact, it has just increased the private sector utilization and encouraged people to go to both public and private. Right? So that doesn't seem to be a very effective use of that $3 billion that we talk about. Right? And when we also looked at the data from our record, so we looked at the actual utilization, admissions to utilization of our patients. So we were able to verify that in fact voucher and non-voucher users, the blue bars are people who use voucher. Their attendance in the public sector clinics was exactly the same as people use in the orange dots, which are people who are non-voucher users. The utilization of the general outpatient services in the public sector primary care is the same whether you have used a voucher or not. Of course, you look these voucher claims we already talked about. And then from the focus group findings of health, you confirm that the voucher users use it for one-off rather than for chronic disease. And they also said that the problems, of course, there were lots of issues because many of the services, the elderly were unaware of the services, especially for allied health services. Right? So these were a lot of the issues of the voucher because it's not well designed. Right? So the thing is, of course, whether one should have been looking at whether it's more cost-effective to make, which is to provide the primary care, than to purchase or to buy from a sector, either through supply or demand side. Because the cost for the government providing primary care services is $3 billion a year, and the total amount voucher claim in 2018 was $2.8 billion, and the primary investments in primary care increased by 90% of the voucher program. So we invest a lot in primary care, but it really had no effect in terms of the chronic disease or preventive management, and no effect on the relief of the public sector pressure demands. So that's why I need to talk about switch purchasing for chronic disease. Okay. So you need to determine the service based on the needs of the population. Yeah.
Okay. I'm sorry, but the time is up. So I would like to ask Ken first. Ken, do you mind if we steal some of your time? Because it's already here.
Yes, by all means, no problem. Please carry on, Professor Yeoh.
Okay, I'm sorry, Ken. Check out this right.
No,
Please,
no need
please.
to
Yeah,
apologize.
I just quick one kick. I'll finish in 5 minutes. One needs then to the first question to make up, and then to who to buy, from whom, what to buy, from who to buy, how to buy, and how much to pay. Right. So I won't go into these details. So I think it's important that who to buy, and then for whom to buy, whether you want to extend coverage, equity. This for UHC. I won't repeat this. And for purchase to be strategic, you need to look at how you actually buy and do the your groundwork, what to buy. And then obviously one needs to target what you're going to target, because in Hong Kong we should be targeting chronic disease prevention and management, because this is the problem to address the segmentation of public and private sectors. So what to buy, one should target. So it's not just a matter of buying anything. Right? I'll skip this. I just want to cover this issue about, if you want to buy, whether it should be using demand side or supply side. And of course, the literature is that voucher works is a consumer-led demand financing tool. And it's been shown to be effective if targeted to a specific group for a specific health service for well-defined and time-limited, in particular for those services which are underutilized. So in fact, when you look at the literature, vouchers have been used mainly in developing countries for reproductive services, but it's also been used for primary care services, other primary care services, but very rarely for chronic disease, because because chronic disease tends to be more complex. They're not well defined. They're not time limited, and of course also in terms of the services that you need to design for, right? So we think that the vouchers are more appropriate to be used for one-off things like screening, and then for chronic disease management, contracting would probably be a more effective tool. Right? Yeah, I'll end by talking about, because there are some decent references which you can look at. There are some in the literature, because one of my colleagues did a scoping review of publicly supplied chronic disease prevention programs. So the references here look at 4 systems, right? Text-based systems. These are some of the references for you to look at in terms of some of the privately supplied chronic disease programs that have been reported in the literature on text-based systems. In social health insurance systems, there's also is targeting chronic disease by the private sector. In mixed health systems, like Hong Kong and Singapore, are very similar, where they provide chronic care for patients with diabetes. And this is an interesting one, is another one where they really gave subsidies for drug delivery, but the patients had to pay the private sector co-payments. Right? So there's one on the privately provided chronic disease programs in private sector dominated health systems in the United States. Right? So those are just, I won't go into details. Those are reference for you to look at if you're interested. So sorry for taking up your time, Kenneth and Sita, for